the confusion is probably just related to the infection or the sepsis. This is how older patients manifest, right? So a lot of times you hear stroke team to the ED, and a lot of times those patients, especially if they're older, head CT is going to be normal. They have altered mental status because of infection or what have you. The coughing and the vomiting, so you worry that the coughing could be indicative of some sort of a pulmonary process, and it's supported by the chest radiograph. But then, the vomiting also could be due to either just the sepsis in general, or could actually be part of the problem, right? So the likely source seems like it's the lungs. So what factors influence the choice of antimicrobial agents for this patient? So, you think about the patient's age, you think about whether or not it's hospital acquired or not, and you think about where is the most likely spot for the infection, right? So the host, where did the host come from, where the host is now, and then what's the host been through? These are the things that you think about. So what would you think about appropriate in this patient? So it might be related to aspiration, so maybe an aspiration pneumonitis, or it might just be due to patient had an operation on their abdomen, they're not really breathing that well, they're splinting, so they're not taking deep breaths, so she's got an pneumonia. She's been in the hospital for 4 days at least, so then this is more of a hospital-acquired infection than it is community-acquired, so you'd have to treat, other things you wouldn't necessarily treat from the community, okay? So these are the things that you think about, right? The initial gram stain results, what you think the pathogen might be based on the patient and where you think it might be, and then what other problems does the patient have. We worry about antimicrobial resistance, right? It's a problem. This is why we wear yellow gowns in certain rooms. Most of this is from misuse of antibiotics to this point, and the continued misuse of antibiotics, right? So we worry about antimicrobial resistance, when we're in a setting where we have resistant strains or resistant strains are known, or patients come from a place or they've been on a lot of antibiotics before. For a lot of our patients, that's a yes. They have been on or they are on a lot of antibiotics. Anyone who's been in the hospital for an extended period of time, certainly anyone who's been in the ICU for an extended period of time. Anyone who's on dialysis because they're constantly in and out of the dialysis center exposed to other people who are relatively ill, so that, that sort of tends to be a place where we find a lot of antimicrobial resistance. Patients that come from nursing homes, so again, these patients have been on and off antibiotics, so they have a really high risk of bringing with them resistance organisms. And then certainly patients with immunosuppression, are going to have bugs that we haven't seen in a while because they don't usually cause infection, and now because of their immunosuppression, they're sort of at risk. So for community-acquired pneumonia and an immunocompetent host, we'd use a beta-lactam and a macrolide. So macrolides are the mycins, erythromycin, clarithromycin, that sort of thing. Or fluoroquinolone. So fluoroquinolone are things like levofloxacin or ciprofloxacin. The problem with fluoroquinolones in our community is that they've been so overused that a lot of bugs are resistant to fluoroquinolone in this area. And we would think about clindamycin, adding clindamycin for aspiration to cover anaerobes. For community-acquired immunocompromised pneumonia or patient from the community who's immunocompromised, you give them Bactrim, so that's trimethylsulfamethoxazole, and you think about adding an antifungal agent as well. Okay? So for nosocomial or ventilator-associated pneumonia, so you'd think for this lady, probably more likely to be a hospital-acquired infection, you give a third or fourth generation cephalosporin or a beta-lactam, beta-lactamase combination, so something like piptazo, or a carbapenem, and the carbapenems are drugs like meropenem, imipenem, ertapenem. You think about vancomycin or linezolid for Staph aureus, and when I was a resident, nobody had Staph aureus infections, or if you did, it was just because you had endocarditis, some injection drug use or something like that. Now Staph aureus causes a lot more infection than it used to, and MRSA certainly even causes a lot more infection. The bad news for all of us is that we probably all harbor MRSA. So if one of your family members ever gets sick and they say it's a gram-positive, they should be thinking about MRSA. And that said, it used to be only in healthcare workers and people from healthcare facilities. Then I started to see it in the kids of people from healthcare facilities, and now it's a lot more common in the common population than it used to be. Like you hear about a lot of athletes have MRSA. Not a lot of athletes, but you hear, dreaded MRSA is in the Giants locker room or the Yankees locker room or whatever, blah blah blah. I think it's a lot more popular is not the right word. It's a lot more common than it used to be. If you think somebody has Pseudomonas, then you would use an anti-Pseudomonal beta-lactam like piptazo or cefepime or imipenem or meropenem. And a lot of times for our patients for Pseudomonas aeruginosa, it tends to be resistant. So we'd add a drug like polymix into it. So that's why you see a lot of our patients on polymix as well. So a 22-year-old college student with possible meningitis. Hold on for 1 second. Right? So a 22-year-old college student with possible meningitis, right? And this is supposed to show petechiae that you can see with Neisseria infection, right? So Neisseria meningitis is something that causes meningitis, right? So you think about, in this patient, usually they're going to have either Neisseria or strep pneumo as the cause for their meningitis, right? So pretty common things that cause meningitis. So we'd start off with something like ceftriaxone, which is a third-generation cephalosporin. And then again, if you're worried about penicillin-resistant strep pneumo, you think about vancomycin. And then once you find, if you prove that somebody had Neisseria, you give penicillin G high dose because it's a bactericidal. It'll actually kill the bug. It won't just stop it from growing. How about a 48-year-old renal transplant recipient with possible meningitis? So what do you worry about in this patient? 48-year-old renal transplant recipient.
Greater risk of immunocompromise.
So not greater risk. This patient's by definition is immunocompromised. So no, greater risk is correct. I would say almost 100%. Because this patient's probably on steroids, and the patient's probably on some other drug like cyclosporin or something. So he is purposely, or he or she is purposely immunocompromised. So in these patients, you certainly worry about the things that usually cause meningitis, but you also worry about something like listeria, and for that you'd have to add ampicillin. Okay. How about a 35-year-old with traumatic brain injury and a ventric, an EVD for 4 days, who has fever and worsening mental status? So now what sort of extra thing does this guy have that you might not worry about in somebody else? So he has or had a ventric, right? So he had something from the outside going into the inside. So if he had meningitis or ventriculitis, right? This isn't a 35-year-old who just, acquired Neisseria or strep pneumo from, a colleague. This is a 35-year-old with a TBI who we worry about us as good a job as we do at washing our hands and doing everything like that and handling the catheter correctly. You worry about something like Staph aureus in the cat being a part of the infection, or you worry about gram-negatives, which you wouldn't necessarily see that often. And in that case, you'd add vancomycin, and then you'd want to be on a 4th-generation cephalosporin like cefepime or something like that. Okay? How about a 75-year-old with bicuspid aortic valve and suspected endocarditis? So that's a bicuspid aortic valve is abnormal, right? Usually the aortic valve is tricuspid. So endocarditis, so what usually causes endocarditis? What are the usual bugs for endocarditis? So you worry about 2 gram-positives or 2 groups of gram-positives in general. You worry about staph, and you worry about strep for sure, okay? And you want to give a bactericidal antibiotic in somebody with endocarditis. So you want to give high-dose penicillin or ceftriaxone plus an aminoglycoside and something like Vanco or Dapto. And these patients are treated for a prolonged course. You all right?
Oh, yeah, I'm fine.
Usually 4 to 6 weeks, all right? How about the 35-year-old with a dialysis catheter, fever, hypotension, and purulent discharge at the site? So what do you worry about that patient?
No more dialysis, do that.
So not only no more dialysis, do that, what else do you worry about? What are you going to say to the resident or the attending?
It looks like it's infected.
And?
Discharges from the sleep.
Okay, and?
Hypertension.
What? Yeah. So you said to me, geez, Jace, are you going to remove the catheter? I'd be like, oh, gee, Carlin, I wish I had thought that was stupid. Yes, I'm going to remove it. Right? No, look, we're partners, right? I mean, if you don't think we're partners, that's my fault. But we're partners. You're in the room with the patient for many hours during your shift, many more hours than I can be. If you say to me, did you see this catheter, Jace? This looks bad. I think you should take it out. My response would be, oh, okay, well, let's take it out. Geez, that's a good idea. I'll take any good idea at any time, right? So removing the catheter is a big part of what you do, right? You get a bunch of blood cultures, right? Somebody said we have to treat the problem, so not only do you have to take out the catheter, the guy's hypotensive, right? So he's got to get fluid resuscitated, but he's a dialysis patient. I understand that, but he still needs fluid resuscitation. We're going to fluid resuscitate. We're going to put him on appropriate antibiotics. So what do you worry about in this guy? So where is he from? He's from a dialysis center. So what do you worry about? I worry about everything, Jason. That's right. You're going to worry about You know, he's got probably a whole bunch of resistant drugs, right? You know, maybe you talk to the place where he gets dialysis. What sort of infections have people from this center gotten? What sort of bugs are you worried about, right? So you certainly worry about Staph aureus. If he has Staph aureus, I would bet $1 that it's going to be MRSA, so he's going to be vancomycin or linezolid, right? And then you'd worry about gram negatives as well, right? So early on, you'd want to see a gram stain. Early on, you'd want to cover for gram negatives as well as staph and strep, right? So the guy's going to get vancomycin, and he's again going to get a 3rd or 4th generation cephalosporin. And then you might even think about, you know, covering for fungus because this guy's in a lot of trouble, all right? How about the 68-year-old with abdominal pain, fever, diffuse scarring, rebound tenderness? What are you going to suggest to me in this guy? Well, geez, Jace, does he need an operation, right? Right? Do we have control of the source of the infection? So not only do we need to give appropriate antibiotics, we need to have control of the source of the infection. If he has perforated diverticulitis with a big abscess, we can give all the antibiotics we want. I can write for every antibiotic under the sun, and you can spend every minute of your shift just hanging another antibiotic, right? And it won't make a damn bit of difference if we don't deal with the problem inside, right? So we worry about intra-abdominal infection, this guy, right? We'd get a surgeon involved early, and then again, we would usually use in a patient like this, something with a beta-lactam and a beta-lactamase inhibitor like pip-tazobactam and or a carbapenem. And then we would think about even adding something like vancomycin if we thought it was, you know, gram-positive, like enterococcus or something like that. All right, a 32-year-old pregnant woman with fever, vomiting, tachycardia, and suspected pyelonephritis. Hold on, wait to pause. I want to pause just so that